and cavitatory formations are seen. The most commonly affected areas are the anterior segment of the upper lobe, the middle lobe, and the lower lobe. However, it can affect any segment. Dense and homogeneous consolidations are generally observed, but nodular and linear pattern is occasionally seen. The chest X-ray of pulmonary tuberculosis will be discussed subsequently by the radiology department. Diagnosis by acid-fast bacilli microscopy. Sputum microscopy is the most widely available test for the active tuberculosis. It is cheap, rapid, easy to perform, and widely available. But it is not a highly sensitive tool because it requires 5,000 to 10,000 bacilli per ml of the sputum to reliably identify the bacilli. The sensitivity of the test ranges from 34 to 80%. Stains used are Z-tensile staining and fluorescent staining. Drawback of it is it cannot differentiate Mycobacterium tuberculosis from the other mycobacteria. Diagnosis by mycobacterial culture. It is the gold standard test for the diagnosis of tuberculosis and more sensitive and specific than sputum microscopy, as it requires only 10 to 100 microorganisms per ml to detect the Mycobacterium tuberculosis. So following are the culture medium that are used: solid downstream Jensen medium, which is the gold standard we use, and the automated liquid culture system. Drawback of it is time consuming, possibility of contamination is present, and it needs an infrastructure and trained manpower. Now, diagnosis by nucleic acid amplification test. The CB-NAT, that is cartridge-based nucleic acid amplification test system, detects the DNA sequences that are specific for Mycobacterium tuberculosis complex and rifampicin resistance by the polymerase chain reaction. It concentrates the Mycobacterium tuberculosis bacilli from the sputum samples, isolates its genetic material from the captured bacteria by sonication, and subsequently amplifies the genomic DNA by PCR. Results are obtained from unprocessed samples in 2 hours. And CB-NAT is the mandatory for the universal drug susceptibility testing. Diagnosis by line probe assay. Line probe assays detect the DNA sequences that are specific for Mycobacterium tuberculosis complex as well as the mutations conferring the resistance. The PCR amplified products are reverse hybridized on nitrocellulose strips containing the probes that are specific for Mycobacterium tuberculosis and the mutations that are associated with the drug resistance. The first line probe assay detects the resistance to rifampicin and isoniazid, while the second line LPA detects fluoroquinolone class resistant and second line injectable class resistance. Now coming to the treatment of pulmonary tuberculosis. The aim of the treatment is to render the patient non-infectious, break the chain of transmission and decrease the pool of infection. We have to decrease the case fatality and the morbidity by ensuring a relapse-free cure and minimize and prevent the development of drug resistance. Now, the commonly used drugs are isoniazid, dose is 5 mg per kg daily, rifampicin 10 mg per kg daily, pyrazinamide 25 mg per kg daily, ethambutol 50 mg per kg daily, and streptomycin 15 mg per kg daily. Now, treatment of pulmonary tuberculosis, that is a regimen for drug-sensitive TB cases. They are divided in 2 phases: intensive phase and the continuation phase. Intensive phase are followed for 2 months, consisting of the isoniazid, rifampicin, pyrazinamide, and ethambutol. Whereas continuation phase is followed for 4 months, containing drugs isoniazid, rifampicin, and ethambutol. In pulmonary tuberculosis is mandatory. Now this is the dosing schedule for adults. We can just have a look on it. Moving on to the monitoring of the treatment response. Sputum sphere microscopy should be done at the end of the intensive phase and at the end of the treatment. A negative sputum smear microscopy result at the end of the intensive phase may indicate a good prognosis. Whereas, if the sputum result is positive at the end of intensive phase, then the continuation phase will be initiated and it will continue till the DST results are available and modified if warranted after the results of DST. At the completion of treatment, a sputum smear or the culture should be done for every patient. And for drug-resistant TB, chest X-ray will be carried out at the end of the intensive phase, end of the treatment, and whenever required. CVR should not be done as a follow-up sputum examination as it detects the dead bacilli only. So we can have a false result. Long-term follow-up, that is after the completion of the treatment, the patient should be followed up at the end of 6 months, 12 months, 18 months, and 24 months. Now, drug toxicity. GI intolerance is the most common side effect of the anti-tubercular drugs. ATD-induced hepatitis is also seen, and the patient should be educated about the signs and the symptoms. That is, the loss of appetite, nausea, and should be instructed to see the healthcare provider if these manifestations occur. Now, the common side effects seen with the drugs like isoniazid is peripheral neuropathy, skin rashes, hepatitis, psychosis, and seizures. Rifampicin has gastrointestinal like abdominal pain, nausea, vomiting, hepatitis, generalized cutaneous reactions, thrombocytopenic purpura. Pyrazinamide has arthralgia and hepatitis, whereas ethambutol can cause retrobulbar neuritis. Now, talking about some special situations. First, if the patient has HIV with tuberculosis. So, among the HIV infected person, the treatment of TB is the same, that is in HIV negative TB patients. We have to first start the anti-tubercular drugs, and we will start the ART as soon as the treatment is tolerated. It is started between 2 weeks and 2 months. In pregnancy, except for streptomycin, the first-line anti-tubercular drugs are safe to use in pregnancy. A breastfeeding woman should receive a full course treatment, and breastfeeding must be continued. After ruling out active TB, the baby should be given 6 months of isoniazid preventive therapy. In renal diseases, isoniazid and rifampicin are eliminated by biliary excretion, so there is no change in the dosing necessary. 3 times per week administration of these two drugs at the following doses is recommended. Pyrazinamide at 25 mg per kg and ethambutol at 15 mg per kg. In situations like liver diseases, modifications of the drug is required. First condition, if the AST and the ALT levels are more than 3 times the normal and there is presence of symptoms, that is patient is symptomatic. And second condition, if the AST and the ALT levels are more than 5 times normal and the patient may or may not have the symptoms. So, thank you everyone.
A very warm good afternoon to one and all present here. My name is Japji Kocher and I feel privileged to take this rostrum to brief you about radiology in tuberculosis. Also, I would like to extend my heartfelt gratitude towards my team members who've helped me through this. My team members are Jaisho, Chirag, Jay and Subhoshmita. Radiology is an art of finding answers in shadows. And aren't we curious? It is a very useful tool in our day-to-day clinical practices. Name it, like diagnosis, screening, monitoring progress of treatment, and monitoring progress of disease. Before jumping on to a pathological chest X-ray, I would first like you all to know what a normal chest X-ray looks like. Before interpreting the radiograph, we all should keep 5 points in mind. Patient's identification details, in which view X-ray has been taken, whether the film is in inspiration or expiration, X-ray penetration, whether it is under or over penetrated, and rotation of the film. There are 6 major views of chest radiograph: posterior anterior view, lateral view, anterior posterior view, lateral decubitus, a picogram, right and left oblique view. Yeah. This is the lateral view of a chest X-ray. In posterior anterior view, you can appreciate that the clavicles are projected over the lung fields. An anterior posterior view, you can see that the clavicles are presented above the apex of the lung fields. In posterior anterior view, the X-rays are projected from the back of the patient to the front, and in anterior posterior view, the X-rays are projected from the front of the patient. This is a chest X-ray showing normal findings. Air appears black and soft tissues and bone appear white. This is the trachea, if you can appreciate. In the entire length, this is the spinous process. You can appreciate ribs and clavicle here. This structure is known as carina. This is the right hilum and the left hilum. The right hilum is slightly lower than the left hilum. On the left side, you can appreciate aortic knob along with left ventricle, and on the right side, you can appreciate right atrium. Do not forget to notice claustrophrenic and cardiophrenic angles, because blunting of these angles will definitely indicate a pathology. This is the right hemidiaphragm and this is the left hemidiaphragm. Left hemidiaphragm is slightly lower than the right hemidiaphragm due to the weight of the heart. Types of radiological patterns in tuberculosis. It presents itself as primary TB, post-primary TB, miliary TB, healed TB. Also, I forgot to tell you that if there is any shifting and deviation in trachea, it also indicates a pathology. Right now, it is in its normal position. If it deviates to the side, you need to check for the pathology. Also, note the heart size. This is the cardiac diameter and this is the thoracic diameter. Dividing these diameters, you will get a cardiothoracic ratio, and it should be below the value of 0.5. You will also identify gastric bubbles, which is a normal finding. Also, these are the right hilums and the left hilums. Types of radiological patterns. It presents as primary tuberculosis, post-primary tuberculosis, miliary, healed, and complications. Primary tuberculosis, the most common abnormality in children is lymph node enlargement, and you can appreciate airspace consolidation along with lymph node enlargement. This chest X-ray is showing dense homogeneous opacities in the right, middle, and lower lobe of the X-ray, and in this chest X-ray you can appreciate bilateral hilar adenopathy. Here. This chest X-ray is showing Bond's focus, which is very pathognomic of primary tuberculosis. And when Bond's focus calcifies itself, it becomes a Rankes complex. This is a chest X-ray PA view showing pleural effusion. You can appreciate opacities here in the lower lobe. Along with that, there is classical blunting of cardiophrenic and claustrophrenic angles. Pleural effusion is usually unilateral and due to subpleural infections. Coming to post-primary tuberculosis, in this chest X-ray, you can appreciate focal or patchy heterogeneous consolidations involving the apico-posterior segment of the upper lobes and the superior segments of the lower lobes. This is a chest X-ray I derived from the radiology department in our college. This is showing consolidation, cavitation, dense fibrotic shadows and nodular opacities all in one. On the right side, you can appreciate that there is this thickening of walls and it is showing that this is a cavitatory lesion here. Along with that, you can appreciate consolidation in the upper region of the lung. On the left side, you can appreciate dense fibrotic shadows with dense nodular opacities. This is again an X-ray showing cavitatory lesion. This is an axial view, high resolution computed tomography showing cavitatory lesions along with tree in bud appearance, which is indicative of an active disease. Coming to miliary tuberculosis, in this chest X-ray, you can appreciate millet seed-sized opacities of 1 to 3 mm in diameter distributed randomly all over the lung fields. This is a chest X-ray of miliary tuberculosis. It refers to a widespread dissemination of TB by hematogenous spread, seen more frequently in immunocompromised patients. This is again an axial view HRCT showing the similar pattern of miliary tuberculosis. Coming to complications, this is again a coronal CT of lung that I took from the department. It is showing lung abscess with pleural effusion and collapsed lung. Here you can appreciate that the lung is collapsed, the arrow. Along with that, you can see the lung abscess and pleural effusion on the outside with crowding of ribs. Coming to bronchiectasis, it is another complication, and this is in high HRCT, coronal view showing dilated bronchial trees bilaterally. This is an HRCT axial view showing encysted fluid in posterior aspect of right pleural cavity. This is an HRCT of tuberculous empyema. And this is a chest X-ray showing empyema, where you can see opacities and disappearance of cardiophrenic and claustrophrenic angles. Along with that, when empyema communicates with the bronchial tree by bronchopleural fistula, it can show an air fluid level. This semicircular thing here dehydration, biliary mottling, lymphadenopathy, or pleural effusion, then the disease is considered to be active. If you see fibronodular scarring, calcific lymph nodes, or volume loss, it means that it has healed itself in some point of time. This is a chest X-ray showing healed tuberculosis. Here you can appreciate apical thickening and right lung volume loss as compared to the left lung volume loss. I've tried to incorporate as many X-rays as I could. Thank you so much for your time and patience.
A very good afternoon to all the respected dignitaries, faculty members, and my fellow colleagues. Today, our group of 5 students, Priyakshi Seni, Charchit Agarwal, Rohit Bhargav, Yash Prajapat, and myself, Sara Sadar, are here to give a presentation on the topic Pharmacotherapy of Pulmonary Tuberculosis under the guidance of Dr. Anusha Vohra ma'am and moderator Dr. Shipra Jain ma'am. Classification of anti-tubercular drugs. Anti-tubercular drugs, according to WHO 2016, are classified into first-line drugs, Group A, Group B, Group C, and Group D. Group A are the fluoroquinolones, Group B are the second-line injectable drugs, and Group C are the second-line oral drugs. And Group D are the add-on agents. In this PPT, I will discuss in detail about first-line drugs. Isoniazid. Isonicotinonic acid hydrazide is most effective, cheapest, least toxic primary anti-tubercular drug. It is tuberculocidal for rapidly multiplying bacilli but static for resting bacilli. It is effective against both intra as well as extracellular organisms as it can freely penetrate inside the cell and can grow in the walls of tubercular cavities. Isoniazid is a microsomal enzyme inhibitor of CYP2C19 and CYP3A4, so various drug interactions may occur. It is metabolized in liver by acetylation by N-acetyl transferase enzyme. This enzyme converts isoniazid into acetyl hydrazine. According to genetics, there are 2 types of people, fast acetylators and slow acetylators. Fast acetylators have high NAT concentration and slow acetylators have low NAT concentration. So the dose has to be adjusted accordingly. Coming to mechanism of action, isoniazid enters mycobacterium and gets activated by the enzyme catalase peroxidase. This enzyme is coded by CAT-G gene. Now, if there is a mutation in CAT-G gene, high isoniazid resistance is seen. This activated isoniazid then binds with acyl protein reductase and acyl protein kinase, inhibiting their function, therefore inhibiting mycolic acid synthesis, which is a major component of cell wall in mycobacterium. Now, if there is a mutation in these genes, then low isoniazid resistance is seen. Ethionamide shows cross resistance with isoniazid as it also inhibits this enzyme. Coming to the drug interactions, para-aminosalicylic acid competes with acetylation of isoniazid, prolonging its T-half. As isoniazid is a microsomal enzyme inhibitor, it will decrease the metabolism and increase the blood levels of various drugs. Coming to the adverse effects, peripheral neuritis. Isoniazid blocks activation of pyridoxine into pyridoxical phosphate, causing this. So, a prophylactic dose of 10 mg vitamin B6 is used. This is more common in slow acetylators due to accumulation of isoniazid, whereas hepatitis is more common in fast acetylators due to accumulation of acetyl hydrazine. In case of CNS toxicity, psychosis and seizures may occur. Drug of choice is 1 gram IV pyridoxine for every 1 gram isoniazid. In case drug dose is not known, 5 gram pyridoxine is used. Gynecomastia can also be seen. Coming to the second drug, rifampicin. It is bactericidal to Mycobacterium tuberculosis and many other gram-positive and negative bacteria. It acts best on slowly or intermittently dividing bacilli. Both intra and extracellular bacilli are affected. Its mechanism of action is by binding to the RNA polymerase enzyme of Mycobacterium. It inhibits amylase synthesis, leading to tuberculocidal effect. B gene codes for this enzyme. If there is a mutation in that gene, then rifampicin-resistant tuberculosis is seen. Coming to the pharmacokinetics, rifampicin has to be taken on empty stomach, undergoes enterohepatic circulation. It is a microsomal enzyme inducer, so it will hasten the metabolism of various drugs like warfarin, oral contraceptives, anti-HIV drugs. So in HIV patients, rifabutin is used instead of rifampicin as it has low enzyme inducing property. Coming to the adverse effects, GI disturbances, flu-like syndromes, CNS symptoms, and staining of secretions like tears, saliva, sweat with orange-red color is seen. So patient has to be counseled beforehand about this and has to be advised to use glasses instead of soft contact lenses. Coming to the next drug in this category, pyrazinamide. It has weak bactericidal action and more active in acidic medium. It is more lethal to intracellular bacilli and to those at inflammation sites, so is most effective when inflammation is active, which is in starting 2 months of the therapy. Mechanism of action is pyrazinamide is a prodrug, so it gets converted into pyrazinoic acid and inhibits fatty acid synthase type 1, killing the mycobacteria. It has very good penetration in CNS, so is useful in meningeal tuberculosis. Pyrazinamide is the most hepatotoxic drugs among all the first-line drugs. Hyperuricemia, nausea, vomiting, arthralgia, that is joint pain, photosensitivity, and hypersensitivity reactions are other adverse effects of pyrazinamide. Coming to ethambutol, it is the only tuberculostatic drug amongst all the first-line drugs. Fast multiplying bacilli are more susceptible to it. It hastens the rate of sputum conversion and prevents development of resistance. It acts by inhibiting arachidonic transferase enzyme and disrupts the microbial cell wall formation. Half the dose of ethambutol is excreted by kidney, so it is very unsafe in kidney failure. Most common adverse effect is eye toxicity like retrobulbar optic neuritis and red and green color blindness, so it has to be given with high caution in children less than 6 years of age. Coming to the next drug, streptomycin, which now comes under the group B of second line injectable drugs. It is an aminoglycoside which has action tuberculocidal. Because of need of IM administration and lower margin of safety, it is used only as supplemental first line anti-TB drug. In case of streptomycin resistant infection, it must be stopped at the earliest because the risk of streptomycin dependence is there. It acts only against extracellular organisms due to poor penetrating power. Its mechanism of action is by inhibiting peptide protein synthesis of mycobacteria by binding to the ribosomes. The adverse effects includes ototoxicity, nephrotoxicity, local pain and sterile abscess due to injection. Role of steroids in tuberculosis. Corticosteroids are usually not used in TB patients. However, they may be used under specific clinical situations like in tubercular meningitis, tubercular pericarditis, and extrapulmonary TB. In AIDS patients with severe manifestations of TB also these are used. The mechanism of action is by suppressing the inflammatory response associated with TB. The common adverse effects are osteoporosis, increased risk of infections, GI issues, mood swings, and increased blood sugar levels, which may lead to increased weight gain. So, coming to the summary, rifampicin stains the secretions, and ethambutol can cause eye toxicity. Fluoroquinolones are contraindicated in children as they cause damage to growing pathways. You must remember anti-tubercular drugs causing hyperuricemia like ethambutol, pyrazinamide, which may manifest as increased uric acid blood levels and joint pain. Also, anti-TB drugs causing hepatotoxicity are all the first-line drugs and ethionamide, bedaquiline. So, liver monitoring should be done. Antitubercular drugs causing neuritis or psychosis are isoniazid, specifically causing peripheral neuritis, cycloserine, linezolid, ethionamide, pyrazinamide, and ethambutol, causing specifically optic neuritis. Now, I would like to invite Dr. Karan Kumar sir from Department of Hepatology to continue this further.
Good afternoon, all. We have all heard about how to diagnose tuberculosis, what are the drugs available to treat tuberculosis. So, to treat tuberculosis, is that so easy? Make a diagnosis, you have drugs available with us, just give the drugs and patient will get okay. No, it is not like that. All the drugs which are consumed has to first pass through the liver. The second year pharmacology student must have heard about the first pass metabolism. All the drugs which are taken by mouth, they are absorbed from the lumen of GI tract and via portal vein they first reaches the liver. Liver tries to detoxify that drug and in a excretable form so that it can be excreted from the body. So basically all the drugs which are taken has to pass to the liver before it reaches the systemic circulation and before it reaches to the tubercular bacilli where it can be killed. So, among the drugs which we have already discussed in the last talk, the first line drugs isoniazid, rifampicin and pyrazinamide, when they passes through the liver, as they are metabolized by the acetylation pathway or the cytochrome mediated pathway, they can cause injury to the liver. They can cause per se damage to the liver, which is known as hepatotoxicity. Any toxicity which occurs due to drug to liver, which is not intended to, it is known as hepatotoxicity. So what happens when a drug is taken? Either the patient tolerates, liver being a healthy organ, regenerative organ, tolerates whatever it is being exposed to and doesn't show any effect. These people are known as tolerators. Some people show transient rise in derangement of liver function test and gradually adapt to it. They are known as the adapters. Some people don't adapt. Once they get exposed to the anti-tubercular drug, the liver gets a major injury and the liver injuries continue. They are the susceptible individuals. These susceptible individuals, they can present as either mild symptoms as nausea, vomiting, or in form of derangement of liver enzymes as elevated transaminases, or they can have jaundice. Very rarely, I can say that 1% of those patients who develop this liver injury, they can land up in acute liver failure, which warrants urgent liver transplant. So, while prescribing ATT for any tuberculosis, the patient has to be monitored very carefully. So what are the risk factors by which we can identify this susceptible population? If the age of the patient is more than 35 or is less than 5 years, as compared to male, female are at more risk. If a person has cofactors like alcohol, obesity, diabetes, as discussed in the first talk, testing for diabetes and HIV is mandatory before starting anti-tuberculosis treatment. While the clinician should also be aware of taking history of alcohol, and if the patient is obese, they will be more cautious while prescribing this first line of ATT. If the patient had abnormal baseline liver function test, then while giving these hepatotoxic agents, we should be more careful. HIV, hepatitis B infection or hepatitis C infection at baseline increase risk of ATT-induced liver injury. If the patient is hypoalbuminemic, which is the case in most tubercular patients, caution should be kept while taking this anti-tubercular. Apart from these, there are some other things: acetylation status, the HLA phenotype, or the gene polymorphism, which could not be detected but determine whether the patient is adapter or susceptible to anti-tubercular. So, what should be done so that this type of acute liver failure or mishappening should not happen with this drug? Before starting a ATT, liver function test in form of bilirubin, AST, ALT, that aspartate transaminase and the adenine transaminase should be done. If the patient has any risk factor which is mentioned in the previous slide, the patient should be monitored carefully with LFTs every second weekly, at least for the induction phase, which is of 2 months. And if any times ALT level crosses the 5 times of upper limit, the upper limit is 40 in males and 18 in females. If any time ALT level crosses 5 times of upper limit, the ATT should be stopped. If the patient had baseline derangement of LFTs, or if there is any pre-existing liver test, then the frequency of LFT should be even narrower. Instead of 2 weekly, they should be monitored every 3rd day or every 5th day. So, a simple take-home message is all the first-line ATP drugs, rifampicin, isoniazid, and pyrazinamide. They carry significant hepatotoxic potential, careful screening of liver function tests, and all the other risk factors which can increase hepatotoxicity should be done. On treatment, there should be regular monitoring of health. Thank you.
Thank you, sir. Now, I, Pramiti Parikh, would be presenting on the topic extrapulmonary tuberculosis. The presentation is prepared by myself and my fellow colleagues Hemant Pushpat, Indu Sharma, Mandeep Benewal, Divyansh Saxena, Divyanshi Upadhyay, and Nandini Bhatt, under the guidance of Dr. Taranuja Sir and moderator Dr. Nirvika Gupta ma'am. The term extrapulmonary tuberculosis is used for occurrence of tuberculosis at body sites other than lungs, which include pleura, lymph nodes, abdomen, genitourinary tract, skin, joints, and bones or meninges. The risk factors are as follows: extremes of age, which include less than 15 years or more than 65 years, female gender, immunosuppression, and people residing in high incidence TB countries. The signs of extrapulmonary tuberculosis are in the following order: lymph nodes, which are the most common site, then pleura, genitourinary tract, bones and joints, meninges, peritoneum, and pericardium. It is uncommon in thyroid, pancreas, myocardium, and muscles. The symptoms are site-specific, like headache, vomiting, seizures, abdominal mass, psoas abscess, kyphosis, etc. Tuberculosis lymphadenitis. Lymph node tuberculosis refers to Mycobacterium tuberculosis infection of the lymph nodes and may occur as the sole manifestation of tuberculosis or alongside pulmonary or miliary tuberculosis. It's the most common form of extrapulmonary tuberculosis in India, accounting for around 35% of extrapulmonary tuberculosis patients. Among all tuberculous lymphadenitis, cervical adenopathy is most common, constituting 45 to 75% cases, but inguinal, axillary, mesenteric, and mediastinal involvement have also been described. Tuberculous lymphadenitis may present a spread of infection from tonsils, adenoids, sinonasal, or osteomyelitis of the ethmoid. Central nervous system tuberculosis is the most severe form of TB. It is almost always fatal if left untreated, and even with currently available ATT, mortality rates remain high. It results in high mortality or morbidity in the form of severe neurological sequelae in almost 50% of people despite treatment. CNS TB may involve any part of nervous system, including meningeal, parenchymal, and spinal tuberculosis. Skeletal tuberculosis is common chronic infection of bones and marrow. It's the most disabling form of TB. Appendicular skeletal joints such as hip, knee, ankle, feet, shoulder, elbow, wrist, and hand can also be affected by TB. The diagnosis is molecular type, direct microscopy, including green-Nielsen staining and fluorescent staining, and the culture on the LJ media. Other test modalities include histopathological examination, biochemical examination, and radiological examination. The treatment remains same as pulmonary TB, depending on the drug susceptibility or drug-resistant EBV. Thank you.
Good morning, esteemed dignitaries, professors and faculty, seniors and my dear peers. My name is Aditya Bensla, and today I, with the help of my team, Yash Khandelwal, Samarth Singh, Maiti Singh, and Tejas Mehta, have prepared a presentation on the topic of the National Tuberculosis Elimination Program under the aegis of the Department of Community Medicine, with the guidance of Dr. Rajat Vora Sir, Professor and Head of Community Medicine, and moderator Dr. Niti Gehlot Ma'am, Associate Professor. Taking a look at the tuberculosis burden in India, the incidence is 188 cases per 1 lakh, and the HIV negative TB mortality is 36 cases per 1 lakh individuals. Looking at the HIV positive TB mortality, it is 0.78 cases, and the total number of HIV TB cases per 1 lakh individuals is 3.8. If you look at the state-wise prevalence of tuberculosis per the 2021 survey, the state of Delhi leads with 534 cases, and the state of Kerala is last with 115. Taking a look at the Sustainable Development Goals that have been set by the World Health Organization, they envision a world free of TB with the motto Zero TB deaths, Zero TB disease, and Zero TB suffering, with the goal to end the global TB epidemic that is, have less than 10 cases per 100,000 population. The indicators that they have decided on, which have to be achieved by the year 2030, are reducing the number of TB deaths compared with the 2015 percentage by 90%, reducing the incidence of TB compared to the 2015 percentage by 80%, and reducing the amount of TB affected families that are facing catastrophic expenditures to 0%. Now, taking a look at the evolution of the National Tuberculosis Elimination Program, in 1962, the Government of India launched the National TB Program alongside several district TB centers. This was later on changed to the revised National Tuberculosis Control Program in 1997 with the introduction of the DOT scheme, which is Directly Observed Treatment, short course. This went through various changes and in 2017 was changed to the National Strategic Plan with a focus on patient-centered care for TB elimination. In 2020, the Government of India again revised this plan to what it is today, the National TB Elimination Program, and in 2021 launched the TB Mukt Bharat Abhiyan. Taking a look at the TB Mukt Bharat Abhiyan, India is committed to end TB by 2025, this 5 years ahead of the global SDG target set by the WHO. On the 13th of March 2018, the Prime Minister of India launched the TB Free India campaign at the Delhi End TB Summit. This campaign calls for a social movement which is focused on patient-centric and holistic care. The criteria for ending TB in India is to have no more than 44 new TB cases or 65 total cases per lakh population by 2025. The objectives of this Abhiyan are to provide additional patient support to improve treatment outcomes of TB patients, augment community involvement in meeting India's commitment to end TB by 2025, and leveraging corporate social responsibility activities. Taking a look at the National Strategic Plan now, it is comprised of 4 primary pillars: the detect, the treat, the prevent, and the build pillar. We will be examining all of these in slight detail. The detect pillar involves a few major strategies, such as using high-efficiency diagnostic tools for early diagnosis, scaling up of newer next-generation molecular platforms, promoting and fostering research for new diagnostic tools, early detection of drug-resistant tuberculosis using the universal drug susceptibility testing, and building capacity for diagnosis of latent tuberculosis infections. Looking at the treat pillar, it involves providing a daily regimen using fixed drug courses to all TB patients, using drug susceptibility to guide treatment for drug-resistant TB, providing a patient-centric approach to treatment, and ensuring that there is no loss at cascade of TB care. The prevent pillar involves sustaining COVID-appropriate behavior, scaling up airborne infection control measures, treating for latent TB infections that have come into contact with confirmed cases, and addressing social determinants of TB through intersectoral approach between ministries, government agencies, NGOs, and other various stakeholders. Finally, the build pillar involves the planning for integration of services under the National Health Mission, the control of TB drugs through appropriate laws, regulations, and policies, capacity building in HRD, positioning TB high on the health and development agenda, and ensuring universal access to TB care services. The NICSHA scheme is another program that has been launched by the Central TB Division in collaboration with the National Informatics Center, which is a web-based application. It involves several salient features, such as the NICSHA Poshan Yojana, which provides 500 rupees per month to all TB patients as a direct benefit transfer for nutrition assistance. It also provides travel reimbursement at the rate of rupees 750 to any individuals who are coming from notifiable tribal areas. There are also several treatment support incentives at the rate of rupees 2,000 for drug susceptible TB and at the rate of rupees 5,000 for drug resistant TB. It also involves a notification scheme wherein private providers are provided rupees 2,000 as an incentive by the NTEP for notification and successful outcome of a TB case. These can all be accessed through the NICSHA portal. It also involves several adherence schemes to ensure that there is follow-up between patients and providers. The Pradhan Mantri TB Mukt Bharat Abhiyan launched the NICSHA Mitra scheme on the 9th of September 2022. This scheme involves individuals or corporations providing additional support to any on-treatment TB patients. This can be of various types, such as nutritional support, additional investigations, vocational support, or additional nutrition supplements. The shortest period of time that one can commit as a NICSHA Mitra is 6 months, and the longest is 3 years. The NICSHA scheme also involves a NICSHA Sampark call center, which is the number you can see here, which can be used by any provider or patients or anyone who has any doubts relating to the NICSHA scheme. Thank you.
Now, I would request Dr. Mahesh Mishra our HOD Pulmonary Medicine, to deliver his words of wisdom on this topic. Dr. Mahesh Mishra.
10,000 years before crisis era. It is also mentioned in the our Vedas, Yajurved. It is also got mentioned in the Bibles. And tuberculosis is also detected from the Egyptian mummy. So this is not a new disease. This is a very old disease. Before 1950, all the new drugs come into the after 1950. Before 1950, there was a sanatorium approach for the tuberculosis treatment available. The German medical students came from the Germany to the Himalaya, sent by the government, and returned, after getting cured, returned back to his country and submitted thesis on the sanatorium treatment for the tuberculosis. That was the basis of sanatorium treatment for the tuberculosis. And it was it was applied for the long years. It was the only after 1944 stigmatitis was discovered. Later on, the function isolated Eisenberg discovered. It was after 70s there was an era of short course chemotherapy, which are in action now. So several celebrities of different fields, like famous mathematician Ramanujam, famous poet Munshi Premchand, a very powerful president of very powerful country, America, Roosevelt, very affluent class, wife of wife of Dr. Pandit Jawaharlal Nehru, Kamala Nehru, was died due to tuberculosis. The famous scientist Lennox, which contributed immensely to the medical field, like many innovations. He was also died to the tuberculosis. What I intend to say that tuberculosis do not respect anyone, whether it is rich, whether it is poor. It do not differentiate on the basis of wealth, age, sex, caste, gender, race. In our India, it is a silent killer. It is silent killer. It acting as genocidal. No any other infectious disease cause more mortality other than tuberculosis. It causing more death in children. It is a leading cause of mortality in the woman, more than maternal mortality. It affects younger population between 15 to 50 years. It means it affecting the socio-economic productive group. If any disease which is affecting socio-economic group, that will take nation behind. What is this kills 1% every minute in our India. If you calculate in the year, tuberculosis causing more than 5 lakh deaths per year in India. Despite of available effective anti-tubercular drugs. Cheap, available, effective anti-tubercular drugs. Why it is so? It is because of lack of awareness in the doctor community, there is social stigma, and lack of political and bureaucratic commitment toward the tuberculosis. What happens? Symptoms are same right from the 10,000 years before crisis. Symptoms are similarly described till death. there was a with the availability of modern diagnostic tools like spectroscopy, molecular test, culture, things are improving. A lot of needed to create awareness in the doctor community. I hope this kind of CCR will create awareness about tuberculosis our future generation doctors. And I'm really happy that our management and our provision, Dr. Pramod, take initiative as a tuberculosis as a part of initial UGCR. Thank you very much.
Thank you, Dr. Mahesh Mishra.